Amadi, my name is Neto.
Dr. Neto is from Nigeria, and for years, he worked as a doctor helping patients until one day when he saw a big problem. People were afraid to go to the doctor, not because of this or this. They were afraid because of this. Money. See, going to the doctor, getting medicine, all of this is really expensive. And because of this, many people don't go at all, putting their health at risk. So that's why Dr. Neto decided to start
Wella Health.
Wella Health offers health insurance, but it's much cheaper than regular insurance.
We call it micro-insurance.
Wella Health covers basic care for things like malaria, typhoid, heart health, and diabetes. You pay a tiny bit every month so that when you get sick, you can afford the doctor you need.
We are a health-first company. Money should never stop anybody from going to see a doctor.
Today, Wella Health is helping thousands of people in Nigeria, and soon it will be all across Africa. We need more people like Dr. Neto because nobody should ever let a lack of money make them afraid of the doctor.
Ladies and gentlemen, welcome into the immersion of a bustling Nigerian clinic and the diversity of a city in this beautiful country of Nigeria as we welcome Dr. Ikpeme Neto of Wella Health. Doctor, hey, my hat. For you, go ahead.
Thank you, Anita. Good morning. My name is Dr. Neto. And I want to tell you a story about this young boy named Fortune. Lives with his mother in a slum in Lagos, Nigeria. Fortune became unwell with malaria, but his mother was concerned. She couldn't afford to pay, and so she kept him at home, hoping he'd get better. When she finally did take him to the clinic, it was too late. Fortune got really sick and ended up dying. The fear of paying out of pocket for healthcare led to Fortune's death. This story is repeated thousands and thousands of times across Africa. Now, I worked as a doctor for over 10 years in multiple countries across the world where this was not a problem. But I was concerned that people that looked like me didn't have access to affordable healthcare. And so I quit my job, bought a one-way ticket back from New Zealand, and landed in Nigeria to solve this problem. Because what happens is a lot of us pay out of pocket for our healthcare, over 70% of us in Africa. And that costs $44 billion every year. Now, insurance is a great way to solve that. But current insurance is too expensive. And insurance companies have to work with thousands of fragmented healthcare providers that use manual systems. And that's where we come in. We provide technology to help insurance companies innovate and provide really affordable healthcare plans that start at less than $1 a month. We cover common conditions such as malaria, typhoid, and provide cash payouts for hospitalizations. And we deliver it via a network of community pharmacies. And we make money from commissions, subscriptions, and service revenue. Now, patients have cheaper, better quality care, and the providers we work with grow their revenue, and we support them to improve quality. I'm particularly proud that we've impacted about 300,000 people since we started. We work with over 2,000 pharmacies, 25 insurance companies, and have paid out over $2.5 million to these pharmacies to help their businesses. Last year, we did just under $1 million in revenue, and are projecting over $6 million in the next few years, where we're going to be profitable. We're going to grow via landmark distribution partnerships we signed with a number of enterprises in Nigeria, and our goal is to scale across Africa and impact over 10 million people and be in every single African country. The vision that I'm building is one where nobody has to suffer because they don't have money to pay for their healthcare. Thank you.
And it's now time for a Q&A. Ibukun Diane, over to you.
Thank you very much, Dr. Neto. I'm Nigerian, so obviously I'm familiar with the issues you raise. I also happen to have had the privilege to serve as chairman of an insurance company that dealt extensively with that. And as I was chairman of First Bank, agency banking, and all of the things that affect what you're doing was a key part of the work I did in those offices. Now, you have 2,100 and something pharmacies. Now, I'm trying to think of the standard pharmacy that has a pharmacy in-house, and the many quack pharmacies which are more regular in neighborhoods. And I would first like to know, how do you select the pharmacies you work with? And how many of them have certified pharmacies in-house? And the risks associated with that whole model itself. Because if someone goes through your process and they get quacked, if I use my constructed English,
Yes.
you know, how does that affect your entire model? Because all you need is a distrust moment at one of the points. How does that impact the ability of the people you're targeting to believe in the model?
Yeah, absolutely. Thank you so much for that question. You hit the nail on the head about the big problem here is quality control for low-cost care. And that is really where our innovation has come into play. Like I said, I worked as a doctor for many years and trained. And what we do, first of all, is the pharmacies that we bring on board have to pass certain quality checks. So they do have to have a pharmacist there. They need to have the right registrations. We audit their supply chain, for instance, because fake medicines is a problem. We make sure that the medicines that they provide have a mobile authentication system where SMS can be sent to make sure that the drugs are proper. And we have a 5-point scale where we continuously score the pharmacies every single time they see a patient. So we have had calls to kick people off the network. Why we are important is we aggregate a lot of this demand. So that when we tell pharmacies what to do, they listen to us because we're starting to give them significant chunks of revenue, 10, 20, even 30% of their revenue. So this aggregation means that we're able to actually impact the quality that they provide, as well as the ongoing support via our agents, our pharmacy agents that go out to teach, train, and also support them.
Now, what you're trying to solve is critical.
Yeah.
But I'm also looking at the constraints. The right pharmacists that you need are the ones in the cities and in a bit more affluent neighborhoods. The bulk of the people that are your target customers are the ones who live outside of those regions, and they're usually in the neighborhoods where the kind of pharmacists that you need are not as readily available. So there's a mismatch. So I'm trying to get at how you're thinking of solving that problem. Otherwise, the largest number of people captured in your target market are not able to access what you're offering, even though it's a solution that they need. But the infrastructure is a challenge.
Absolutely, yes. And again, that's what we're building, that infrastructure. So what we do, we have algorithms in place for conditions, for instance. So when somebody steps in, we've got support to the professional that's there. So if it's not a pharmacist, if it's a lower cadre, they're able to leverage the tools that we give them. So it's a mobile application. They're able to interact with, report back to us, and we have a quality check as well with the customer when they go through that process. So it's algorithms, it's really live support that they can speak to, and ongoing quality audits and checks to ensure the quality is great. And actually, we recently got a grant from the Gates Foundation to extend this beyond just pharmacies that we know to chemists, which is really where the bulk of the market is. And we're starting to work with a lot of chemists to make sure that we're able to actually get to everybody.
Thank you. Thank you, Dr. Neto. It's a brilliant idea. I think insurance penetration on the continent is the lowest globally. And health insurance is actually very critical. Because we don't have a health insurance, we have people actually die because of that, as you said earlier. So my question is on the business model. Looks to me you're trying to get the patients directly to the pharmacists without getting people to see a doctor, because that's still, I think, very important. So that's one. How do you do that? And it's like your job, your profession, you're making it irrelevant. So that's one.
Yes.
And then this seems to me a big problem that is difficult to solve with one brilliant startup because it's a sort of public policy failure, and it's an ecosystem that has to be built. So how do you believe you can actually grow in Nigeria and beyond Nigeria? Because public policy in all these different countries is different, and it's really building an ecosystem, and I doubt it's really possible with one man with a great idea.
Absolutely. Thank you for that question. So yes, I'm trying to remove doctors a lot of times because the challenge is we do not have the doctors on the continent, right? A lot of my doctor colleagues are all leaving. I'm the exception. I returned, and I saw that there was a huge gap. And so the reality is that our patients, our people, don't have doctors anyway. So what I'm doing is actually helping them use the channels they already use. So if you look across Africa, the first port of call a lot of times is the local pharmacist or local chemist. Who's supporting them? Wella Health is now. So we're actually making the current channel people are using provide better quality care. So that's key. Now we have remote support with telemedicine, doctors on the phone that can support the pharmacist or the chemist and can actually also advise the patient. So there is that remote support. But the key thing is actually, the lower skilled healthcare worker, can we give them tools and support to provide great quality care? And we're answering that, with the work that we're doing. So yes. The next question is around public policy. You're absolutely right. And so actually, at the start of this year, we launched a public care sector outfit. And so we actually work with 2 state governments in Nigeria because we know that it's really important to work with the state governments. So we are not kind of competing with them. We're actually building infrastructure to help them. So now state health insurance schemes in Nigeria can actually work with our infrastructure, our technology, to help their providers, help their patients, collect payments, route things around, make sure quality is good. So we're totally embedded with the way the public sector is doing things and helping them to innovate and do things quicker, faster, and better with our technology and processes.
Thank you.
Hi, Dr. Neto. I have 2 questions, one about how your business works and the other one a little bit more personal. The first question, you are providing an insurance product, right? Which means that you are taking risk, insurance risk, underwriting that risk, because there's a subscription model where people pay a monthly fee or a fixed fee. And how do you manage that risk and how do you price the product?
Yeah, thank you so much. So we are not an underwriter ourselves. We work with existing insurance companies. And then what we do is help them figure out the data they require to price the risk appropriately. Prior to us, people were very scared of doing retail. And Mr. Washika will tell you that people don't really do retail health insurance because it's very difficult to really price the risk in. What we've done is enable that to happen. We've collected the data, we've gone out and done the work. We built the infrastructure to deliver that care really affordably. So if you compare to, say, if you went into the usual channel to, say, have a malaria claim done, it would cost you somewhere about, say, $20 to $25 even if you go to a high-end clinic. You can't do a low-cost plan doing that. Using our own systems, we get it as low as $2 to $3 per episode. So that changes the economics of it. So we provide all this data and systems to the insurance company, and then we work with them to actually price the risk in. Now, our plans are capped in that we cannot pay out beyond a certain amount. And so once we know that, we're able to actually write policies or write plans that can be profitable. And then we don't take the risk ourselves, the insurance company does. So we just take a cut of the commission and the service fee as well. That's how we make money.
And how many insurance companies do you work with?
So we service 25 insurance companies, which is about half of the health insurance companies now in Nigeria. And we're underwriting with about 2 insurance companies.
Okay.
Yeah.
Now, my second question. You talked about you were in New Zealand, right? And you saw this problem, and you were motivated to go back to try to provide a solution. Can you give a little bit more color around that decision? Was there a particular event or somebody talked to you? And when you made that decision, what do you say to your friends and family around in New Zealand? How do you really come to that decision?
Yeah, everybody thought I was crazy, because like I said, most doctors were leaving and I was returning. But I think the turning point for me was, I was sitting in a clinic, sitting in hospitals, giving people really great care. And my mom back in Nigeria started to have challenges with her own healthcare. And I felt that how can I be giving care to others that my mom couldn't get? And all the money in the world, all the success anywhere else didn't matter if my mom and people that looked like me couldn't get great health care. And it was an easy decision to make, and I came back.
I have one question, and it's nagging at me. Your target market, they're not sophisticated. Your whole model can be put easily at risk because what you're covering is so narrow. The alternative to the ailments that you're covering is easy for any one of them that has a bit of sense to go into the pharmacy and buy for a few hundred nairas malaria treatment or any of those things. Now, maybe typhoid is a little more advanced, but if they have something a bit more, and they tend to in some other ways, and they're under your plan, and by the time they go to your care, it's not covered. Like you said, there's a cap.
That's right.
And things go wrong. They are not going to remember because they never read the contract.
That's right.
To be honest. They're not going to remember that they were not covered for that. They're just going to communicate that they were paying, but you didn't save them when they needed to.
That's true. Yes, again, big risk. How we've approached that is really around how we attract the customers and education and building trust. So first is that, we distribute using a number of agents and embedding it as well into, so Airtel, for instance, we sold 40,000 plans with them, for instance.
I use the 50 naira call a doctor thing on Airtel.
Yes, exactly. So we're embedded into that. So you call a doctor, you get all the other benefits as well. And so once you sign up, there's an onboarding process.
Okay.
So it's SMS, where we kind of tell you what to do. And to be honest, sometimes we do provide exceptions, because you're right, you need to actually serve people, so you have testimonials that people can go and speak about. But it is a challenge, and we are solving it by essentially trying to educate people and build trust.
So I have a last question on numbers. I was looking at your projections, and to be honest, your profit margins are not impressive, and they're even erratic in your projections. I'm wondering, what do you, because this, you're not taking the risk. The risk is taken by the insurance company. You earn a commission. You are distributing with channels using, the MTN and Airtel of this world. Why is your profit margin this low, and why is it erratic like that?
Yes, so the reason is historically we did a lot of experiments. We're startups, so we're trying to figure things out. So we experimented with a lot of channels, a lot of products, a lot of different things. We're now in a phase where we have a good sense of what the product looks like, what the channels look like. And honestly, over time, we see ourselves expanding beyond just being in the middle, because you could get squeezed on either side, either by the distributor or by the underwriter. At the moment, we're focused on solving the service layer, which is really difficult to do, and also creating that product that we can embed. And once we do that, we are in a position of strength to either go downwards towards the underwriting side, or potentially do more on the distribution side. So I think over time, where we get to will actually be getting licenses to be able to carry more of the risk as we go along.
Thank you.
Still have a bit of time.
Still have a little, yeah. And you have multiple insurance products, but this micro insurance thing is quite interesting. Can you just talk a little bit more about that? Explain what that is?
The micro insurance?
Yeah.
Yeah, so it's essentially bite-sized insurance. It's really affordable, so we can embed it into various channels. So you just pay a small amount. In some instances, it's 50 naira, which is something like 10 cents. So for that small payment, you get a certain cover. So malaria care, whenever you're sick, you go to a pharmacy near you, they do a test, and they give you drugs, and that's covered. You don't need to pay any more cash. So essentially, it's small payments that covers a basket of conditions that are common.
How do the patients pay? How is it digital or?
So it depends on the channel. So if it's via a telco, it's embedded into how they pay to the telco, so airtime, or it could be mobile money, or we also have agents as well that go around and collect cash.
Thank you.
Thank you.